Hello, I'm Dr. Lloyd Ratner, and I'm the Director of Renal and Pancreatic Transplantation here at Columbia University New York-Presbyterian Hospital. And in this video, I hope to tell you everything that you really need to know about donating a kidney. And it's our general philosophy that the more the patient knows, ultimately the better they're going to do. So let's start from the very beginning. In terms of the recipient is best served and will do better if they're able to get a live donor kidney as opposed to a deceased donor kidney or staying on dialysis. Now, in terms of kidney transplantation versus dialysis, the advantages of kidney transplantation are, number one, the recipient could live longer. And in general, the results are that people in general live about twice as long with a kidney transplant as they would if they had stayed on dialysis. Number two, they'll feel better. Number three, they'll have more control over their lifestyle. And number four, they should be able to have a more lenient diet. So again, the advantages of a kidney transplant relative to dialysis are live longer, feel better, more control over the lifestyle, and eat better. Now, in terms of a live donor versus a deceased donor transplant, a live donor transplant is better for the following reasons. Number one, the person generally doesn't have to wait on the waiting list, and that often enables recipients to be transplanted preemptively before ever requiring dialysis, and that's a big advantage. Number two, anytime we get a kidney from a deceased donor, there's about a 50-50 chance that the kidney won't function appropriately initially. And that makes the whole post-operative course more difficult and a greater risk for complications. With a live donor, the kidney will work appropriately right from the get-go about 95% of the time. So things just go smoother, and there's really much less risk for complications with a live donor transplant. Number three, the risk of rejection usually is a little bit less with a live donor transplant. And number four, and most importantly, the long-term results are better with a live donor transplant than with a deceased donor kidney transplant. So if someone gets a kidney from a deceased donor, there's a 50-50 chance that the kidney will last for 10 years or more. If they get a kidney from a live donor, 50-50 chance that the kidney will last for 20 years or more. And if they're lucky enough to get a kidney from a perfectly matched brother or sister, 50-50 chance that the kidney will last for 35 years or more. So there's a huge advantage if people could get a kidney from a live donor versus a deceased donor. So for all those reasons, we try to encourage live kidney donation. But that said, we don't want to create a problem where there isn't one. So that's why we put the donors through very extensive evaluation process. Well, what are we looking for in this evaluation process? Well, first, we want to make sure that the donors don't have any diseases that they could potentially give the recipient, such as things like hepatitis, HIV, cancer, etc. And usually those are screened by just blood tests. Number two, we want to make sure that it's safe for the donor to undergo surgery and anesthesia. Number three, we want to make sure that long-term the donor is going to be okay with just one kidney. And then number four, we want to make sure that from a psychological standpoint, the donor understands what they're getting themselves into, that they could give an informed consent, that they are that they're not being coerced, that they don't have any unrealistic expectations about the whole process, and that if things don't work out for any reason, that they don't become pathologically depressed. And then finally, in terms of the donor, we have them undergo a CAT scan to make sure that they do have two kidneys, that both kidneys are normal, and that we have a roadmap to do the surgery with. So that's why you have, as a donor, you have to go through this whole extensive evaluation process to make sure it's going to be safe for everyone involved. Now, if everything checks out okay, it's generally very, very safe to donate a kidney. But that doesn't mean that there's no risk. Worst case scenario, anybody could die from any operation, and donating a kidney is no exception. the chance of dying from donating a kidney is roughly equivalent to the risk of being killed in a car accident over a 1-year period here in the United States. Now, I had a fella say to me once, he said, well, he was donating to his brother. He said, well, I've been in 13 accidents in the last 10 years. I said, well, if that's the case, you're safer on the operating table than you are in your own car, as are the rest of us. So we don't think twice about getting in the car every day, but that's about what the risk of donating a kidney is. Now, long term, the risks are so small to the kidney donor that insurance companies won't raise their life insurance premiums, they won't raise their health insurance premiums, they won't deny them insurance. And I think that tells us a lot, because we all know an insurance company will never cut anyone a break in paying premiums if they have a valid excuse to raise the premiums. And in fact, about once a year, once every couple of years, I get a call from a kidney donor who says their insurance company is giving them a hard time. And I've always just written a letter to the insurance company, and it's taking care of it. Now there are even studies that show that living kidney donors actually live longer than the general population. And it's not that taking out your kidney makes you live longer, it's just that we select out only the healthiest people to donate their kidney, and they remain healthy after they've donated the kidney. And in fact, the woman who conducted one of these studies that have shown this is a nephrologist in Sweden who, after she conducted this study, she donated a kidney to her own husband, and both she and her husband are doing well more than 10 years after the donation. Of course, she did the study first before she donated to her husband, but she donated nonetheless because it is so safe to donate. Now, let's talk about the operation itself. The operation that we do is called the laparoscopic donor nephrectomy. And with a colleague of mine and I, when I was in Baltimore at Johns Hopkins University, we were the first people in the world to perform this operation in February of 1995, and now it's become the standard of practice throughout the world. The laparoscopic operation uses minimally invasive surgical techniques. And what we do is we make several small incisions between 1/4 of an inch and a 1/2 inch long. And through one of these incisions, we place a fiber optic TV camera so we could see what's going on the inside without having to make a big incision. Through the other small incisions, we place our instruments. And when it's time to remove the kidney, we generally make an incision between 2 and 3 inches long right over the pubic bone and remove the kidney through there. The old way of doing the operation was to make a big incision across the side, put our hands in, and take the kidney out through that big incision. The advantages of the laparoscopic operation are that, number one, it hurts less, both in terms of how severe the pain is and also how long the pain lasts. Number two, the hospitalization is shorter. So most people spend about 2 days in the hospital. And then number three, and most importantly, the recuperation is quicker. So most people tell us it takes them roughly about 3 weeks to get back to full speed, as opposed to 6 to 8 weeks with the older operation with the big incision across the side. Now, the one catch or caveat to this laparoscopic operation is that with any type of laparoscopic surgery, and taking out the kidney is no exception, there's always a possibility that we may need to convert to the bigger incision during the surgery. And if we have to convert to the bigger incision, then you lose the benefits of the laparoscopic operation. So why would we have to do this? Well, the answer is that this is sort of a safety net. So if we were concerned about injuring the kidney, if we were concerned about injuring adjacent organs like the bowel or the spleen, or if there was more bleeding than we had anticipated, those are all reasons to convert to the larger incision. So we wouldn't know that until we were there in the operating room doing the surgery. And again, if we had to convert, you would lose the benefits of the laparoscopic minimally invasive surgery. Now, I wouldn't worry too much. the chance of us having to convert from the laparoscopic to the larger incision is less than 1%. So it's something you need to know about, but I wouldn't worry about it very much. Now, the operation is done under general anesthesia. And what we do is we bring the donor into the operating room, we put them to sleep and start the operation. Somewhere between a half hour and an hour after we start the donor's operation, we'll start the recipient operation. So there is a time when both the donor and the recipient are in the operating room simultaneously, but the donor's operation starts first and ends first. It generally takes somewhere between 3 and 4 hours on average. Okay? When it's all done, the surgeon will come out and speak to the family in the waiting room. If it's taking longer than 3 or 4 hours, family members shouldn't be concerned. You'd much rather have us take our time and make sure everything's just right rather than trying to rush through to get done in 3 or 4 hours. Don't worry, we'll take good care of the donor and make sure everything goes smoothly. Now, the donor then wakes up in the recovery room, and most donors will have some pain, but we'll make sure that they get plenty of pain medication. After a few hours in the recovery room, generally most of our donors go up to the 7th floor, and all this takes place in the Milstein building, which is our main hospital building. The 7th floor is our transplant floor, and the recipients will also wind up on the 7th floor. So donor and recipient will be close to one another so that they could visit with one another, family members could visit easily, etc. But they won't be in the same room. We keep the donor and recipient in separate rooms. Like I said, most donors spend about 2 days in the hospital, and when they get discharged home with a prescription for narcotic pain medications. Most people tell us that they need the narcotic pain medications for between 3 and 4 days. And then after that, they need over-the-counter pain medication like Tylenol or extra-strength Tylenol for another 3 or 4 days. So in general, they need pain medication for somewhere between a week and 10 days. About a week after being discharged, you'll come back and see your surgeon in the clinic. And if everything's okay at that point, it's not necessary to come back to see us here at the Transplant Center for the donor. However, we do make the following recommendation, that at 6 months, 1 year, and then every year subsequently, the donor should get a complete history and physical with routine blood and urine tests, either by an internist or their family doctor. If they don't have an internist or a family doctor, or if they would prefer to, we'd be happy to see them here. But it's not necessary for the donors to keep coming back to us over the long haul. And the reason for these regularly scheduled visits at 6 months, 1 year, and then every year subsequently are to make sure that the donors aren't developing any other medical problems like high blood pressure or diabetes, which could impact on the remaining kidney. Now, the donors aren't going to be at any increased risk for developing these things by virtue of donating their kidney, but we know that a certain percentage of the population, as they age, will develop these things. So what we want to do, if someone's developing these problems, we want to make sure that if they develop them, they get picked up promptly and treated appropriately to protect that remaining kidney. Once people have recuperated from the surgery, they should be 100% completely normal. No special diet, no limitation on their exercises, no special medications. Like I said, there are shouldn't affect their insurance status. They should be able to get health and life insurance with normal premiums. There are some instances, however, where donating a kidney can have a potential impact. And the first is if the donor is in the military. And this is very variable. It can potentially affect a military person's active duty status. And that depends on the branch of the service they're in, their job, their commanding officer, their medical officer. So if someone's a potential donor and they're interested in donating and are in the military, they should discuss this with their commanding officer and medical officer for their particular unit. The other area where live kidney donation could potentially have an impact is for women who are of childbearing age who hope to get pregnant after they've donated a kidney. Now, we used to always say that donating a kidney should have no impact on their ability to get pregnant, sustain a pregnancy, have a normal child afterwards. More recently, at an international transplant meeting in Australia, data was presented that showed some very interesting findings. The first finding is when they looked at people who donated a kidney and who then subsequently got pregnant and compared them to women, general population, who got pregnant and had babies, there was the risk for things like complications of pregnancy, like gestational diabetes, preeclampsia, low for birth weight babies, prematurity, and all that was exactly the same in people who donated their kidneys versus the general population. So that's good. So there's no increased risk relative to the general population. But what they did is they also went a step further, and they looked at women who had donated their kidneys, who had been pregnant before they donated, and then who had been pregnant after they donated. And when they compared the women from their pregnancies before donation to after donation, and they corrected for age, because obviously they're all older after they donated than they were before they donated, then the incidence of things like preeclampsia, low for birth weight babies, prematurity, and things like that was a little bit higher after live kidney donation. But again, still the risk very, very low and still